Welcome everyone to the International Working Group for Health System Strengthening HSR 2020 session. My name is Laura Hayward and together with Malvika Manoj, we have the pleasure of moderating this session. It's wonderful to be able to be part of such an auspicious symposium.
Throughout this pandemic, we have heard from experts around the world on the need to reinvest in health systems, health communication, strengthen leadership structures, decolonize global health, and much, much more. The International Working Group for Health System Strengthening, or the IWG, was born to inject the voices of emerging global health leaders into the discourse on health systems and more broadly on global health. You will hear more about the IWG in a minute. COVID-19 has highlighted a need to rekindle the spirit of international collaboration and leadership for marshalling action across multiple levels. Developed by the IWG, this session aims to convene public health professionals across multiple levels and reinvent and redefine a vision for global health leadership. We hope to provide a unique perspective to the current discussions on COVID-19, leadership for health, and the way forward through the lens of emerging global health leaders. We will begin with a grounded overview of global health leadership from trailblazer and scholar Dr. El Storil, and then we will dig further into this topic from the lens of emerging health leaders. After hearing from our members on a survey we recently conducted to gauge the perspectives of emerging public health professionals on global health leadership, we will hear from IWG members from Kenya, Brazil, Lebanon, UK, and Philippines. They will provide an overview of their lived and professional experiences during COVID-19 in these countries. Finally, we will end with a call to action activity that we hope you will engage with us in to co-create a vision and some tangible steps to move forward. Now, I will hand it back to Laura for a brief introduction of the IWG and to introduce our keynote speaker for the day.
Thank you. The International Working Group for Health System Strengthening is a collective of emerging professionals in the public health space from around the world. Today, we have our members from across 6 different global regions, from the University of Cape Town, South Africa, Johns Hopkins University of the United States, the American University of Beirut in Lebanon, the Indian Institute of Health Management Research, India, the University of Philippines, Manila, and London School of Hygiene and Tropical Medicine in London. You will all hopefully meet each other later when we do Q&A. Our mission as an organisation is to unite the next generation of strategic thinkers and innovators around the world to co-create equitable and sustainable solutions for complex health challenges. We are delighted you're all joining us today. The session will start with a brief presentation by Dr. Torolo. Dr. Torolo has worked for over 2 decades at the interface of pharmaceutical research and development, human rights and access to medicines, policy analysis and advocacy around biomedical innovation and access. A biomedical engineer by training, Dr. Torolo joined Médecins Sans Frontières Access to Essential Medicines campaign in its pioneering years as a chair for the Drugs of Neglected Disease Working Group, a multidisciplinary think tank to advance needs-driven research and development for diseases that primarily affect developing countries. A key outcome was the creation in 2003 of the Drugs for Neglected Disease Initiative, a non-profit drug development organisation which she joined as a founding team member. It was here that she led several research and development projects from discovery through to clinical trials, which included uncovering and driving the development of phenidazole, which is now available to patients as the first all-oral treatment for human trypanosomiasis, also known as sleeping sickness. Since 2009, Els has held a number of roles in global institutions, led groundbreaking and incisive work around advancing health and human rights, including leading the Access to Medicines and Innovation work at the Open Society Foundations and leading the Access campaign at MSF as its executive director from 2017 to 2020. She is currently a visiting scholar at UCL Institute for Public Policy and Innovation in London. I hope you enjoy this session and will now hand over to Dr. Torolo, who will provide an expert perspective on global health leadership with respect to the COVID-19 pandemic and how we move beyond to create meaningful leadership reform.
Hi, everybody. Good morning, good afternoon, good evening, wherever you are. It's my pleasure, and thank you so much for the kind introduction to be here with you to share some perspectives. I don't think I will lay out what a new leadership for the world for global health will be, but what I can do at least is building on my assessment and monitoring over this past year of what happened looking at COVID-19 vaccines, research and development and access, what we can deduce about the good, the bad and the ugly of current global health leadership. And I hope that that will be a starting point for your further discussions about how can we do better. But so looking at COVID-19 vaccines, what do I think has been extremely good and reflecting of some elements of global health leadership that I think we need to retain. The first is, I think that we have seen an amazing immediate mobilization of research and development response from the first weeks after having detected this newly emerging virus, and in particular, as soon as its sequence was published, which happened early in January. We have seen WHO, its R&D blueprint, mobilizing, convening already early February, a major meeting with experts all over the world, setting a research agenda of what we would need to tackle this newly emerging disease, including laying out a target product profile, for instance, for what a good vaccine would look like. We've seen CEPI, the Coalition for Epidemic Preparedness Innovation, that was actually founded in the wake of the Ebola outbreak on West Africa to actually facilitate and accelerate vaccine production against emerging infections, including what was then called Disease X, the pandemic that we didn't know yet that of a virus that we didn't know yet that existed. They were ready to actually mobilize new research and development. We've seen universities, companies adapting their technology platforms to this new virus, and a major mobilization of government funding. It's estimated that anywhere between 15 and 20 billion US dollars of government funding went immediately into R&D. So that's amazing. As a result, indeed, 6 months later, we've seen the first human efficacy trials of vaccine candidates happening, building on existing technology platforms that had been developed for other diseases, but that were quickly adapted, as I was saying, to COVID-19. And then, as we know, in less than a year, we had several vaccines with demonstrated efficacy and a whole pipeline of, I don't know how many more candidates as a backup. The big pharmaceutical companies have mobilized, but we've also seen new vaccines being developed in China, in Russia, in India, and in Cuba. So it's been a major international response. We've seen calls for global solidarity also from the early days on to say we need these vaccines to be available for everybody. They need to be people's vaccines. And we've seen a WHO coordinated setup of what is called the ACTA, Access to COVID Tools Accelerator, with the idea of let's make sure as soon as new vaccines will be available, that they will be accessible for everybody under an equitable allocation framework. We've seen also the creation of COVAX, which was meant as a pooled procurement mechanism that would actually help to do that equitable distribution. And so today we have 11 vaccines that are authorized in varieties of ways in different countries. And at last, I looked over 550 million doses that have been distributed, given already to people, which is, of course, amazing. However, and moving immediately to the bad, we also know that the way these vaccine doses have been allocated, have been administered, is highly unequal. Over 50% are just for in the US, UK, and Europe only. And to make a very stark comparison, 10 million doses only for the whole of Africa, which counts for more than 1.3 billion people. So the inequality in terms of access is enormous. Now, other than around access, a number of what I think bad things have also happened if you look at the R&D process, because despite all these efforts, there was no global health leadership. There was no coordination of the R&D agenda. There was no portfolio approach. The target product profile that was laid out, companies were not obliged to follow it. And so what we ended up is having a race for a new vaccine with achieving marketing authorization as the endpoint, not necessarily delivering the best possible vaccines. And I have published a few pieces in the BMJ and also in STAT, laying out the details of why this race of a vaccine actually could do more harm than good, despite delivering vaccines, but maybe not exactly the vaccines that we needed. And so collaboration was minimal. It was competition between different vaccine producers to get there first. And so we have clinical trial designs that were focused on speed rather than on answering the most relevant public health questions. For instance, the trials were looking at reduction of symptomatic cases, while the real problem with COVID is hospitalizations and deaths, which happened with more vulnerable populations like elderly, which were not very much represented in trials, etc. There was also a problem of communication in the sense that we learned about the early results of these trials through corporate press release, not in a transparent way through peer-reviewed scientific publications. And it became a cacophony of results that were being presented where you could not compare what one trial was presenting versus the other, etc. And governments reacting based on press releases to inter-purchase agreements. We also saw political pressures on regulatory agencies to speed up approval, which then led to a lot of suspicions about whether the data were actually robust enough to allow approval. And then back to the access side, it's also clear that there was, from the beginning, a lot of hoarding and competition around research and development, technological dominance, rather than actually trying all of us together move forward the best possible vaccines for us all. And what we saw is that actually COVAX, the mechanism created by global health leaders to create this equitable access, was undermined at the same time by the same governments who were, through advanced purchase commitments selectively with certain companies, undermining this whole idea of a collective pooled procurement mechanism that could then allocate doses in an equitable way. There were calls to start sharing technology because it was very clear that manufacturing capacity and monopolies around that would become the bottleneck, but these calls were systematically blocked, in particular by countries that were holding that technology, the Western countries. They were also blocking demands for instance, a waiver on intellectual property rights to share much more the technologies of these new vaccines were also not admitted. And it's not so easy to make the distinction between the ugly and the bad. So I'm going to quickly move to what I think has been really ugly, even though some of the bad were not very nice either. I think that the fact that despite a WHO endorsed equitable allocation framework that really wanted to prioritize vulnerable population and health workers to get access to a vaccine first, and that on a global scale, what we've seen is that countries that had the opportunity to buy vaccines have just bluntly chosen to first vaccinate their whole population, and in an unapologetic way. And I think that that's one of the more ugly things, and supported by populations that are pressuring their governments to buy more vaccines, speed up the vaccination programs. And we've seen really a societal fracture around this me first, us first, and without wanting to take care of the rest of the world. We've seen every country scrambling for vaccines, and where those that were not aggressive enough in trying to get deals with companies were actually falling out. If you don't play hard, you're out. And again, the media and people, the population, criticizing their governments for not negotiating hard enough, for not hoarding enough vaccines, which I think was really ugly. We've seen supply battles, for instance, between the UK and EU around who is entitled for the first supplies of what we know is a limited supply. And then one of the most ugly things is, was last week in the media, where Boris Johnson was quoted to say, being proud about UK's success on vaccines thanks to capitalism and greed. And so the fact that this type of behavior is being elevated as this is actually what success looks like, I think is a really ugly aspect of where we are. And I'm conscious that I'm running a little bit over time. Maybe one final point about what we are now starting to see, what is termed very nicely vaccine diplomacy, where those countries who have vaccines are going to use it or are already using it to buy goodwill on other topics in our geopolitical power dynamics. I think we will see more of that, which risks of turning pretty ugly as well. And so maybe just as a conclusion, I think that despite the fact that this pandemic is like the example of a global crisis where we need to come together, where we need global health leadership, I think we've seen a complete breakdown of any multilateralism, of solidarity. I mean, but it's not just solidarity, it's actually justice. And so I think we really have to start from scratch, rebuilding that global health leadership. And if we see that the leaders that have created the mess in which we are today are talking about coming together behind the global treaty around pandemic preparedness and response, it doesn't give me much trust. And I hope the new generation that you are representing will be able to shake the tree a little bit such that we can build a better global health leadership. Thank you for your attention.
Thank you, Dr. Torilo, for such inspiring and thought-provoking insights. Thank you for underscoring the need for a people's vaccine and to strengthen efforts towards vaccine equity. Your insights and on the need for more transparent communication, global solidarity, collaboration, equity, and justice-centered policies and programs for global health leadership are well noted. Thank you. Next, Dr. Mabel Aoun and Dr. Magali Colonna will present findings from a survey that IWG conducted earlier in March 2021 to see how the broader community of emerging global health leaders understand and conceptualize this need to reimagine global health leadership. We uncovered some really interesting findings, so without further ado, I will pass on to Mabel and Magali to share more about the survey findings with you all.
Thank you, Malvika. Good afternoon, everyone. We have the great pleasure to share with you the results of our IWG survey. The survey was analyzed by 3 members of the IWG, Magali, Bronte, and me. The aim of the survey was to understand the opinion of young public health professionals regarding the reimagining of global health leadership. The survey included 12 questions, and it was sent to all IWG members, posted on social media, and diffused as well to the IWG 6 core institutions. The survey was closed within a week, and we received 98 complete responses. When you look at the graph on the left, you can see that most of the respondents, 66% of them in blue and green, were between 18 and 30 years old. And the graph on the right shows a predominance of women. So this survey reflects mostly the opinion of young female public health professionals. Regarding the occupation, 43% of participants were students and 17% researchers, but we had also overlapping backgrounds like being healthcare provider and student or faculty and researcher at the same time. The geographical distribution of responses across countries shows that the US, India, and Lebanon had a high response rate, but we had responses as well from a total of 21 countries located in the 6 global regions. So those were the demographics. The second part of the survey tackled the question of global health leadership, whether there is a trust in the current leaders and whether there is a need to change. On the right, you can see that trust in global health leadership scored only 2.9 over 5. And on the left, you see that only 1% of participants said there is no need to change. And based on this majority of yes and maybe for change, respondents had the opportunity to explain why there is a need to a global change, or to reimagine, and I will use their own words, to redesign, redefine, restructure global health leadership. The responses were analyzed, coded, and divided into two big categories. The column on the left shows the themes or causes that contributed to the current failure of global health leadership, and on the right, you see the suggested ideas that could induce the positive change in leadership. Regarding the causes of the current failure, a high number of respondents emphasized the hegemony of high-income countries, or what most of them called the global north. The size of the letters in this slide reflects the frequency of these words and thoughts coming back across responses, and power imbalance was highly cited. The sub-themes mentioned and related to the dominance of high-income countries were underrepresentation of low and middle-income countries in decision-making, and inequity in funds allocation, and inequity in vaccines allocation. The second cause of the current failure was attributed to the biased leadership, and this biased leadership mostly was the leadership that was influenced by politicians, the pharma influence, the donors-driven decisions, all leading to a lack of trust. And finally, responses shed the light on the mismanagement at the level of global leadership, mismanagement of human resources, data, research, and funds. Other bad managerial faults were indecisiveness and late responses to the COVID-19 pandemic specifically, and bad choices of priorities. Consequently to all these mistakes mentioned, on the right column, you can see three big themes that appear to be very important to induce a change. Most of all, the inclusive decision-making, inclusion of low and middle-income countries, women, people of color, diversities. There's a need for equitable representation of all countries, collaboration between different disciplines at all levels. The second theme or important change needed and mentioned was ensuring sustainable funds for research and technology. And finally, a lot of responses reflected the importance of knowledge sharing by training more public health professionals, ensuring good communication to the public, continuous update of policies, and experience exchange between countries. And now I will give the floor to Magali to share the rest of the results of the survey.
Thank you, Mabel. So in the third part of the survey, which I'm going to present now, we focus on how global health leadership should be reimagined. We first gave respondents 4 propositions and asked them to rank the propositions according to their level of importance. The 4 propositions were a greater representation of emerging global health professionals, an improved gender balance inside global health organizations, an increased representation of minorities, and a greater representation of low and middle income countries. As illustrated on the graph, more than 90% of respondents rank these 4 propositions as either extremely important or very important, with a huge majority of respondents even ranking them as extremely important. We then asked respondents what roles emerging global health professionals could have in global health leadership. Around 20% of respondents said that emerging global health professionals could provide fresh and innovative ideas, could introduce creative and new advocacy methods, could be a global sounding board for public health reform, and could bring an up-to-date knowledge of technology. Just under 15% of respondents declared that emerging global health professionals could contribute greater time and energy. A few respondents also added additional roles, which included being able to make leadership more sustainable and being more connected to what is happening on the ground. In the next question, we ask respondents to describe in their own words the key skills and competencies that are expected from a good global health leader. We performed a thematic analysis of the responses and identified 8 different categories of skills. The first category that was mentioned was that a good global health leader should have an in-depth knowledge. This included knowledge of different fields such as public health, politics, management, or knowledge of the local culture. The respondents also mentioned that the global health leader should have great communication and collaboration skills. Being a team player and being able to work in multidisciplinary teams was one of the recurring answers. Many respondents also said that a global health leader should be innovative, which included being a strategic thinker, not being afraid of change, and being visionary. Some of the major themes identified in the responses were around equity and moral values. Many respondents declared that a global health leader should be committed to promoting equity and social justice by being ethically driven, by advocating for minorities and not tolerating discriminations of any sorts. The moral values that were expected from a global health leader included kindness, compassion, and humility. Another major category was a focus on accountability and transparency, which was described by respondents as not being influenced by powers, being reliable, and being able to admit one's mistakes. Finally, a few other skills were mentioned, such as being efficient and passionate about global health. In the final question of the survey, respondents were asked to draft a call to action to reinvent global health leadership. All their responses have been summarized in a single call to action that calls for a distribution of power through diverse representation in leadership, holding leaders accountable to building trust and solidarity across global networks that should serve to ensure equitable access to healthcare, and protection of citizens from catastrophic health expenditure. This call to action highlights the need for community-based engagement, transparency, and empowerment of youth to prevent siloed decision-making. It also highlights the importance of promoting collaboration and participatory approaches that prioritize people over profit. Let's now have a look at each part of the sentence separately. First, the redistribution of power meant equipping upcoming health professionals with relevant skills and training to empower them. Second, the diverse representation included a greater representation of those from low and middle income countries, young people, people of color, and gender diversity. Third, holding leaders accountable referred to decision-making transparency, as well as collaboration to avoid siloed approaches to health systems complexities. Fourth, respondents also mentioned that building trust required community-based engagement to hear all voices, and that solidarity had to be built through multidisciplinary approaches that are human-centered. And finally, equitable access to health included health promotion and resource sharing, as well as using digital platforms and technology. We have now covered the key results from our survey on reimagining global health leadership. I will now hand it over to Malvika, who is going to introduce the next part of the session.
Thank you, Magali and Mabel, for the insightful presentation and clear conclusion. Any discussion on global health and leadership would be incomplete without highlighting the underlying influence of power, privilege, and priority setting. So thank you for highlighting the need to promote diverse representation, strengthen accountability, and ensure that equity and justice are at the center of any discourse and discussion on the path to reform. Next, we will hear from IWG regional leaders from around the world, representing one country from each of the 6 WHO regions for an exciting and enlightening bird's-eye view on how the pandemic shaped their own experiences and perspectives on the need to produce meaningful reform and strengthen leadership for health. Handing over to Nadine Nanji, regional leader from the African region, to start us off. Over to you, Nadine.
Good afternoon and good evening, everyone, wherever you are in the world. I will be presenting the case example of Kenya's response to COVID-19 on behalf of the African region for the International Working Group for Health System Strengthening. Although we are all mostly from South Africa originally, I grew up in Kenya and visit often. We also have other members from Kenya and one from Uganda originally. Just so everyone knows that Kenya is situated in East Africa, which is a third world country. Recently, Kenya has actually made substantial progress in improving key health indicators. The government's goal of universal health coverage for vital services such as maternal, neonatal, and child health. Primary healthcare has been reported to be poor, especially across the rural areas. There have been lots of efforts to improve the primary healthcare policy. which commenced in the 1970s until today. I will now give a broad overview of the COVID-19 situation in Kenya. Overall, Kenya confronts certain planning and coordination issues across most of its health systems, both at a local and national level. So for example, the national government is exemplifying leadership with COVID-19 task forces on mitigation measures and communication, but these are not being implemented at the county level. Other issues lie on what measures such as curfew and lockdown are working or not working. In terms of limited resources, Kenya has not had enough intensive care units at only 537. So that means that if we translated this, it was basically only 22 out of the 47 counties had an intensive care unit, and there were very few ventilators too at 256. Further stresses include staff going into quarantine. Also, the government very cleverly used its M-Pesa system through Safaricom. So M-Pesa is a mobile money system where Safaricom used 175,000 agent networks to distribute masks and hand sanitizers, as well as PPE kits to hospitals. Taking all the health systems in Kenya together, the fundamental shortcoming is the mismatch between needs and the available care, in particular, specialist care and the workforce, from doctors to technicians needed to run it. Finally, on the 26th of March, 2021, Nairobi, the capital of Kenya, imposed a full lockdown due to a recent surge in COVID-19 cases. The president restricted travel in Nairobi, as well as stricter curfew of 8 p.m. and the closure of bars. Also, they restricted movement between some counties, but allowed movement in zones which consisted of 5 counties. This is also an example of where an African country has had to deal with a COVID-19 situation. And actually at this time, the COVID-19 cases are just escalating and how much strain the country has had to take. So next, I'll be discussing the lessons learned. Just to summarize these so everyone can keep track, these fall into the categories of data collection and dissemination processes, community health systems, as well as better broadcasts, meaning health communication. Lessons learned could be centered around data visualization and systems, where there is a need for better systems. Health is not just the absence of disease, but the pandemic has shown the government that there is a huge importance in high quality healthcare. Coordination is happening, but depends a lot on counties, which vary in their capacity. Stakeholders such as private facilities are willing to work with the government, provided the issues of delayed payments can be remedied. Financial remedies need to be in place too. The most fundamental lesson is that there needs to be better community involvement in COVID-19 measures in order to strengthen community health systems as a whole. This particularly pertains to health broadcasts on COVID-19 that have been held by the Ministry of Health and promote health behaviors among the population. Kenya, unfortunately, does not currently have a proper vaccine rollout plan and is currently going through a 3rd wave. Lastly, I will give my own perspective on how we can reimagine leadership using Kenya as the lived example. I have visited many rural areas around Kenya over the years, and it has come to my attention that many populations do not have access to appropriate healthcare or education on COVID-19 and other health issues, and this has been verified by various academic references. Leaders must also ensure that the regulations are enforced through proper campaigns. There is a need for better coordination between the government, the private, faith, and your NGO institutions. I would suggest that reimagining of health leadership can take place through utilizing the community health workers within health systems in Kenya, especially to reach the marginalized and vulnerable populations in the rural areas. There needs to be more support with public health measures, as well as combating the stigma towards those recovered COVID-19 cases. There is a need for innovation and creativity pertaining to the variety of communities across counties. This could mean working together with faith leaders and faith healers through congregations and communities as an example. The faith-based sector constitutes a large portion of health services, not just for Kenya, but the whole of the African population, where there are some statistics that show 80% of the population seek traditional or faith healing. Finally, I would like to say that this is a good opportunity to utilize these hidden and informal types of mechanisms in order to reimagine health leadership from those who are trusted as well as valued gatekeepers to many of these vulnerable populations across Kenya and across Africa. Thank you so much. I will now hand it over to Dr. Luana Araújo for her presentation on a case example of Brazil.
Greetings, everyone. My name is Luana Araújo, and on behalf of the Americas region for IWG, I'll be introducing you to the pandemic response in Brazil, my home country. Brazil is a continental country. The map you see shows the flags of the countries that match our states in size, so we can better dimension it. We have more than 8.5 million square kilometers and a population of over 210 million people. That drives a lot of power and also many, many challenges. Health for us is a constitutional right and a duty of the state, which means we must guarantee universal access and a comprehensive and free healthcare at all levels. Our key strategy is primary healthcare, and we have the largest public program of its kind in countries with over 100 million people. That states how solid of a commitment to the 1978 Alma Ata Declaration our health system is. Despite being late to the disease global progression, which gave us time to plan the best use of our resources to respond to the pandemic, we failed that opportunity. Trusting that the system was ready enough, our population was epidemiologically different from those most affected at early stages, and denying scientific evidence, we didn't prepare adequately to respond to a global threat. Moreover, we structured our response based on hospitals instead of mitigation strategies led by primary healthcare, our most sophisticated tool, a mistake that is taking a huge toll on the entire country. 2022 is also an election year in Brazil. We will have presidential elections, and amidst the intense political dispute of the last decades, the pandemic and our public health results became political weapons for many politicians on different levels who have an eye on the presidential run. Given the complexity of our pandemic response and current situation, many lessons could be brought here, but I will stick to those now undeniable. The first lesson is universal access and free healthcare are crucial for both the patient and the system's response, but they are not enough at all. The insufficient or misuse of those tools can terribly undermine a powerful system. The second lesson is that a health system is not composed only by a population, health facilities, institutions, and resources that deliver healthcare services. That is actually the definition of a disease-based system. Education, economy, transportation, infrastructure, all those sectors are part of a responsive, resilient health system that supports people to produce their own health more than the idea of merely meeting specific health needs. Finally, public health is all about tailoring. We cannot blindly adopt a universal solution that may have worked somewhere else, but is based on an unrealistic scenario for another place. Granularity is as important as learning from other successful experiences around the world. So for me, leadership must change, and soon. We must see beyond the accessibility of leaders, but recognize and nurture leadership in every level so they work in partnership and resonate the interests of all. That is community-based leadership. Leadership then would not be the action of changing, but the ability to listen, process, and with that information in hands, prepare multiple individuals with plural backgrounds to be actors of change. That would be equitable power sharing. Progress would be the result of leadership as an active method of promoting consonance across different communities. I see leadership as the anonymous ability to harmonize multiple interests, not the promotion of individual concerns. Low middle income countries must learn that as soon as possible and exercise their leadership across a truly globalized global health scenario. With that final thought, I will hand on to my colleague, Giwa Nasreddin, who will discuss with you the Lebanese response to the pandemic. Over to you, Giwa.
Hello, Anna. So hello, everyone. My name is Giwa. on behalf of the Eastern Mediterranean region of the IWG, I will cover an overview of the pandemic response in Lebanon. So basically, Lebanon is a small country in the Middle East, which is home to over 6,800,000 people, including refugees like Syrians and Palestinians. The healthcare system is 80% private and 20% public. And it's also worth noting that as Lebanon was dealing with the pandemic, it was also passing through one of the worst economic crises since its modern history, with an inflation rate of over 138% reported by the end of 2020. The crisis was attributed to years and years of being led by a corrupted and unstable political system that was never transparent and trustworthy with its people. So imagine having to go through multiple crises at the same time. So how did Lebanon manage the COVID-19 pandemic? So it's one phrase: it lacked evidence and unity. It was at first pretty serious when cases were very minimal, with schools directly closing on March 1st of 2020, and national strategic plans rapidly published by the Ministry of Health and circulated to hospitals on March 10th. Of course, the first lockdown was initiated and the sole airport in the country was closed as well. There was one public hospital in Beirut that was receiving the COVID-19 cases, thus creating major disparities in the society as a whole. The cases were not increasing until the government decided to reopen the airport on July 1st, as shown on the epidemiological curve. Additionally, the Beirut port explosion had occurred on August 4th, which definitely overburdened the healthcare system and led to the loss of a huge amount of much-needed resources. It is worth noting that the lockdowns that followed since then were not based on evidence and well thought of decisions, but rather centralized and authoritative. The community needs were not being heard, social accommodation and support was not being secured, and national plans were not being evaluated and adopted to the context. Then, the cases had suddenly peaked at 6,156 cases per day in January 2021, and that was also attributed to the reckless decisions of the government, which were to not impose strict measurements and policies during the holiday season. This then, of course, led the country into its third lockdown on January 5, 2021. I have always kept wondering about how the government was always revolting back to lockdowns as a way to control the spread of the virus, instead of thinking of other solutions that might be beneficial and accepted by the community that is living through a disastrous economic collapse. I can make things more positive and talk about the entry of the vaccines into the country on February 14. The elderly and the healthcare providers were the first to receive the shots, but the vaccination process has been critiqued to be slow and steady, which is why Lebanon's private sector has recently stepped in to speed up the process by importing at least 1 million doses of the Russian vaccine last week. Lebanon has administered over 100,000 doses of the vaccine as of the past week, with respect to over 453,000 cumulative cases. So, as a public health professional from Lebanon, I am confidently able to list a vast number of lessons learned from the pandemic in Lebanon. I talked about how central and divided the decisions were taken, which is why supporting decentralized systems is extremely important, where decisions and policies need to be set based on everyone's contribution and collaboration, and not just the authoritative groups. Let us listen to what the community needs and let us involve it more into the action plans, and let us build a better relationship between it and the government. There are a lot of people in Lebanon who still do non-political reasons. Lebanon definitely has to invest in technology more often, like machines, electronic health systems, and contact tracing apps. Another lesson learned revolves around data. Data was not taken care of properly during the pandemic. And as I mentioned earlier, the failure of the responses taken was due to the lack of evidence and data-driven frameworks. Also, Lebanon has to integrate the vulnerable populations in the national and local action plans and emergency responses, like the elderly and the refugees. I was actually part of the quantitative research recently that assessed how the COVID-19 pandemic affected the mental health of the elderly people in Lebanon, and almost 75% of the sample stated that they had faced COVID-19 discrimination because of their age. Finally, from the lessons mentioned, reimagining leadership is a necessity to help build a better country. So how do I imagine leadership, you might want? I envision leadership that is accountable and transparent, and that will lead up to community trust. It should also be collaborative and equitable in order to secure proper access and availability of resources. And leadership must definitely be evidence and needs-based. I consider the pandemic as an opportunity for change to provide a more sustainable and safer Lebanon that works through teamwork and joint collaboration instead of division and dissection. Thank you for listening, and I will now hand it over to Mina Tafazoli to discuss the COVID-19 response in the European region.
Thanks, Hua. Hi, everyone. I'm Mina. I'm an American, as you can probably tell from my accent, but I have been living in the UK for a few years, and I'm very honored to be nominated by the European team to represent the UK experience with the COVID-19 pandemic. I'll be telling a little bit about what the lived experience of this has been on top of some statistics to illustrate the overall response. It would be impossible to tell the story of the UK's response to COVID without acknowledging the political trends that predate the pandemic. Since 2010, austerity policies have led to significant budget cuts in the NHS and a trend of privatization of operations and services. Austerity has also impacted social welfare and safety nets, making the most vulnerable rung of society even more at risk. And while it seems like it's been going on forever, the formal withdrawal of the UK from the EU was on January 31st, 2020, an indicator of the isolationist policies of the UK in the last several years. Now, this was the country in which COVID arrived, with the first 2 cases being detected on January of 2020. I'll tell you a little bit about what happened next. In summarizing the UK's response to COVID-19, I want to call out 4 key elements. The first is disease containment. And as you can probably tell from the red X on the slide, this is one aspect of the government's response that is broadly considered to be a failure. The UK first went into national lockdown on the 24th of March, 2020, by which time there were already over 8,000 cases and close to 500 deaths. Other EU countries had already been in strict lockdowns for over a week before the UK acted. By the middle of April, the death toll from COVID was hovering around 1,000 deaths per day, and hospitals around the country were overwhelmed. This brings me to the next topic, evidence-led policy. Unfortunately, there have been plenty of other examples of COVID response policies that have been totally at odds with the objectives of ensuring public health. One that is particularly notable is the Eat Out to Help Out policy from August of 2020, after cases had declined and the country was no longer in lockdown. I remember walking around in Islington and seeing a cardboard cutout of Boris Johnson outside of a tapas bar with a sign that said, "Dinner's on me." This policy was aimed at boosting the economy and morale, but some studies have linked this policy with a spike of COVID cases that led to the UK's second lockdown in the fall. We also felt it was important to call out the deep failures in policy communication regarding COVID. Over the last year, there have been numerous policy U-turns by the government, each with dire consequences. The one that stood out most in my mind was about school openings in January 2021. After Christmas, many scientists were arguing that we should continue the lockdown, but the government never really gave clear guidance. And so teachers went to school, students went to school, and then the next day they reversed policy. Beyond this, the general messaging was also poor. In May, government policy was to stay alert and control the virus, which doesn't really mean anything. Finally, we do want to highlight an area where there has been significant leadership and success on the part of the UK, which has to do with the vaccine. As Els touched on, Oxford University was the first to develop a vaccine candidate for COVID. Their plan was to make it open source. And though that plan didn't exactly pan out, this vaccine is still one of the least expensive ones on the market and will be critical to helping ensure global protection from COVID. The vaccine distribution in the UK has been moving along swimmingly well, and is being led by the NHS. The UK made the call to widen the gap between vaccine doses in order to reach a wider set of the population, and it looks as of now that that was a winning bet. So what are the lessons from all of this? To summarize, one, act fast. It's simple, proactive policies save lives. At every turn, the government waited until the last possible moment to change course. You can't do that when people's lives are on the line. Number two is to prioritize a strong NHS. The NHS has been the UK's lifeline through all of this and a source of national pride. What it needs now is more budget, more staff, and mental health support for frontline workers. Point three, we touched on earlier, policy not based on evidence can be deadly, and social determinants can impact health. It bears mentioning that COVID did not impact people in the UK equally. Those at the fringes of British society were the most vulnerable, and there were massive disparities in outcomes by socioeconomic status. So taking all of this, what does this mean for how we need to reimagine global health leadership? Number one, global collaboration is needed to fight global problems. Isolationist policies like Brexit are preventing this from happening. Global health leaders need to build and maintain public trust with open and honest communication. At every step, global health leaders and institutions need to ask, what am I doing to build trust with the people that I serve? Poor communication and a lack of trust means even the best policy can have no effect. Evidence obviously needs to be the basis of policy. This goes with the point on trust. And this last point around rethinking the trade-off between health and the economy is borrowed from Martin McKee. It's been made plain by the pandemic that as long as people are unwell, the economy will be unwell. Also, you have to start with health. With that, I will hand off to Siddharth.
Thank you, Meena, and greetings, everyone. I'm Siddharth Srivastava, and I will be presenting the COVID-19 response of India on behalf of the Southeast Asia region. Now, to understand India's pandemic response, it is first important to have a context of its health system. Broadly speaking, India's health system is a hybrid of public and private sectors. Despite widespread urbanization across the country over the past few years, up to 68% of the population resides in rural areas. In these areas, there is widespread discrepancy in the distribution of health services, many of which are served by the public sector. In urban areas, there is mistrust across both public hospitals, often due to a perceived poor quality of care, and private hospitals due to exorbitantly high medical expenses. Adding additional complexity is the presence of alternative forms of medicine, like Ayurveda and homeopathy. With this context, as you can imagine, India was hit hard by the COVID-19 pandemic, reporting the third highest global case count and a likely underestimated figure of 162,000 deaths. While many aspects of India's pandemic response were similar to that of other countries, the response was undoubtedly hampered by unique challenges, including India's large geography, overcrowded cities, and a large population. As I returned back from India from Baltimore in the month of February, I recall a surge of misinformation sweeping social media, ranging all the way from conspiracy theories on Facebook to miracle cures in WhatsApp groups. I remember friends and family being confused and fearful at the time. In March, India entered one of the longest lockdowns in the world. While warranted, its implementation was sudden and without a complete understanding of its implications across the different sections of the society. On the day of the announcement, I recall queuing up panicked for hours at the local grocery store with my mother to buy milk and bread in the absence of clear communication on when or even if shops would reopen in the weeks to come. The rushed implementation also led to a mass exodus of an estimated 600,000 daily wage workers, leading not only to a humanitarian crisis, but also increasing transmission risk across the country. Poor compliance to mask mandates and social distancing measures by the general population in the months following didn't help either. Nevertheless, multiple states and districts were able to contain the virus to some extent, following standard operating procedures and scaling up the 4T strategy of tracing, tracking, testing, and treating. With a declining incidence rate and the launch of an ambitious vaccination campaign, 2021 and beyond hopefully could bode better for the country. This, of course, would depend on the extent to which lessons learned from the pandemic are incorporated. Firstly, there is a need to shift focus from curative care to a health promotion approach, complemented by increased investments across health systems. There really is no alternative for a strong public health core. Secondly, there is a need to separate public health functions from healthcare delivery across multiple levels. While efforts to strengthen primary healthcare infrastructure are warranted, there is equally a need to develop a competency framework specific to pandemic preparedness and response upon which an expanded public health cadre can be trained. Thirdly, there is a need to strengthen existing disease surveillance systems that can provide early alerts and enable decentralized, data-driven responses to public health emergencies. Lastly, despite India's development of 2 indigenous vaccines against COVID, the bitter truth is that even as a public health professional, I have found it difficult to convince my own friends and extended family to overcome vaccine apprehensions. Trust and communication between government scientists, journalists, and the public needs to be fostered through openness and transparency. This is the key to an effective management of any health crisis. Perhaps the most dreadful aspect of this pandemic is that it is most certainly not the last one. It has undoubtedly revealed a fractured foundation in India's health system, a foundation that needs to be rebuilt and perhaps fundamentally reimagined. From my perspective, adopting a health policy and systems research lens toward policy planning and implementation could be one of the many ways to reimagine leadership in a post-COVID world. If the lessons learned from the pandemic can be implemented across health systems, history will mark the 2020 epidemic, or Mahamari as we say in Hindi, as the single greatest inflection point in India's progress towards a healthier nation. With that, I thank you for your attention, and I hand it over to Camille.
Thank you, Siddharth, and a pleasant day, everyone. I am Faye Roderos, presenting on behalf of Camille Baladhay. Let me share with you the case example of the Philippines in the Western Pacific region. The Philippines is an archipelago with 7,641 islands, inhabited by at least 110 million Filipinos as of 2021. The first case of COVID-19 in the Philippines was reported on January 20 of last year. As of March 19 this year, we have reached 648,000 confirmed cases, which consistently rose the days after. We are, unfortunately, experiencing a sudden surge of cases this month, reporting our highest number of daily cases at 10,000 cases following the easing of restrictions in the country. To understand the country's response to COVID-19, it is essential to understand the territorial and political subdivisions of the country. The Philippines is divided into regions, provinces and independent cities, municipalities and component cities, and barangays, a Filipino term for the village, which is also the smallest administrative division of the local government. In 1987, the health system was devolved to the local government units, providing them more powers, authority, responsibilities, and resources to promote local governance and accountability for the health system. Devolution was seen as an opportunity to efficiently and effectively manage the country with so many islands. This has been the structure of the country for the past 30 years, with the Department of Health as the overall technical authority, national health policymaker, and regulatory institution. The overall response to COVID-19 reflects this devolved system. Drawing on the H1N1 experience, the Philippines has adopted the same intersectoral approach to the management of the pandemic. The Interagency Task Force on the Management of Emerging Infectious Diseases, or IATF, provides overall direction and policy guidelines. The IATF produced the National Action Plan against COVID-19 that implements the prevent, detect, isolate, treat, and reintegrate strategy. As the country's risk mitigation response, PDITR involves the implementation of minimum public health standards and the coordinated operations to defeat the epidemic, which are localized responses in barangays. This national plan has been through 3 phases. The first was focused on prevention and containment of COVID-19, while mitigating its socioeconomic impact. Phase 2, which began in July 2020, focused on socioeconomic recovery. Lastly, Phase 3, which is ongoing, focuses on managing the health risk while gradually transitioning to full socioeconomic recovery and inclusion of vaccines in COVID-19 interventions. With this, we learned that the pandemic response highlighted chronic systemic and societal issues. First, the intersectoral approach is beneficial, but the presence of too many decision makers and processes gets in the way of effective coordination. The automatic enrollment and immediate eligibility of citizens to the benefits of the National Health Insurance Program helped in covering the costs of testing and inpatient care of COVID-19 cases, especially with the increase in health spending in an environment of decreased economic activity. Third, the inadequate and inequitable distribution of health workers, even before the pandemic, and their increasing exposure to COVID-19 affected the responsiveness of the health system. Universal health care has to be realized soon because of the persistent challenges in accessibility and availability of healthcare products and services, which became more pronounced in this pandemic. The fragmented health information system contributed to difficulties in coordination and in sound decision-making. Therefore, in a reimagined health system, we envision that there is a resilient health system that can rapidly detect, assess, and respond to public health emergencies. Universal health care through primary care should lead the next normal to reduce inequities. There is equitable distribution and sufficient investment on human resources for health and an efficient healthcare provider network. Next, we envision that there is a single national health information system that covers all transactions related to health products and services for both population-based and individual-based interventions. Fourth, there are strong and effective risk communication strategies and community engagement initiatives to respond to current and future crises that facilitates accurate information sharing and a better collaborative participation in the community. And lastly, we envision that policies are research-based and aligned at all levels. So let's build back better together. And as we say in the Philippines, long live, mabuhay. Over to you, Laura.
Thank you, Faye. And thank you to all our regional speakers and the teams behind them. It's so interesting to see the breadth of responses to the pandemic across the globe and how our members have interpreted lessons learned and how we might reimagine leadership. I really think this is a snapshot and it's very representative of the insight and overview that we share as an organisation. I will now pass over to Mina and Joy to lead us in the call to action activity. If you could please check the live Q&A for the link to Jamboard that you'll need to click on or copy and paste into your browser to participate. You can also enter questions into the live Q&A for any of our presenters, either about the survey or the regional case studies, and we'll address those at the end. Thank you.
My name is Joy Moher, and together with Mina, we will delve into the call to action activity. Throughout the session, we've been able to see the different elements of global health leadership that need to be reimagined. We have highlighted the COVID-19 responses throughout the world, the gaps and the lessons learned. These have shown the need for governance of global health institutions to ensure equity and representation of low and middle income countries, gender equity and representation, building trust with the public, improving transparency, and preventing vaccine nationalism. Governments need to work together for effective response towards a healthier world. This should be done in a collaborative response, recognizing the role of corporations, charities, and nonprofits. The priorities highlighted for global health institutions include ensuring access to medicine and technology, investment in pandemic prevention, focus on social determinants of health as they are contributing factors of health inequalities. We should not forget to ensure a focus on mental health as there is no health without mental health, as well as migrant health. There is a need to co-create a vision for global health leadership, and we can all play a part in this. I will now invite Mina to lead us through the first activity.
Thank you, Joy. So I'm is my screen sharing? Okay. So in this activity, initially, our intention was to break out into groups and work on this individually, but instead we're going to work through this together. And what we're trying to do is to collaboratively arrive at a new vision for global health leadership. Joy has helpfully walked us through a number of different dimensions that we believe, based off of our survey, based off of presentations from our 6 regional members, and based off of the speech by Dr. Els, we believe these topics are critical to address in order to ensure that global health leadership is reformed in a post-COVID world. So what we'll do is actually work on addressing some of those issues collaboratively. And the way that we've done it, I think Laura has shared a Jamboard link with everybody in the chat. We have this collaborative whiteboard that we'll work on for the next 10 minutes as we wrap up our session. And on each slide of this collaborative whiteboard, we have 3 key questions. What is not working well in regards to this topic? What would it look like for this topic to be improved? And what are some actions that can be taken to improve? So our first topic is access to medicines and technologies. Dr. Els gave a very powerful presentation at the beginning as to why our current COVID vaccine distribution and actually the creation of those vaccines indicates that our current approach to addressing access to medicines is fundamentally broken. So I invite everyone to add their comments to each of the key questions, and we'll talk first about this first topic: what is not working well today in regards to access to medicines? I invite each of you to speak, and in fact, if somebody would like to raise their hands, we can unmute you, and you're welcome to give some perspective. Okay. While we wait for that. So I think one thing that Dr. Els really tried to point out was that vaccine nationalism, exactly rich countries hoarding access, this isn't just a one-off incident. In fact, we've seen this in other crises as well. And so perhaps one of the things that's not working well today in regards to access to medicines is that our systems don't have an imperative for equity. That we have systems that favor things like patent protections as opposed to broad access to medicines. So I think one thing that would be critical to address based off of what we've heard from Dr. Els and what some of you are helpfully putting on the Jamboard is that we need a better system that prioritizes equity and access to medicines. Now, what would that look like for access to medicines to be improved? Sharing knowledge on how to create these vaccines locally. I think that, as Dr. Els pointed out, is one of the key ways that we can actually ensure global access. Right now, if you have technology that is only licensed to a few manufacturers, that means that inevitably only those that can afford to pay high prices and advance purchase commitments and countries that have the funding to be able to ensure that their access to that medication is not interrupted are going to be the ones that have the higher access. So let's see what else is coming in. Supporting capacity and building research efforts for local researchers studying vaccine technology. I think that speaks to an interesting point about potentially decolonizing our R&D pipeline. If we are able to build a broader set of institutions that have the know-how and the capacity to be able to generate life-saving technologies, then we're actually going to be able to necessarily increase access in those places that don't currently have access to medications. And what are some actions that can be taken to improve access to medicines? Let's see, it looks like this is one where some of us are stumped. Does anybody have any ideas that they'd like to share? You're welcome to unmute yourselves and speak up on this one, because I think this is a difficult question to address. All right, well.
Hi, Mina, this is Els, if you allow me.
I'm sorry?
This is Els, if you allow me. I, for some reason, can't play with the little post-its. I don't have, the chats. But anyway, I'm following, just reading what people are putting. And maybe one thing to highlight here, and it's not an easy solution, but I think you, in your own presentation, alluded to that at the end, and that is that we need to find a better way to integrate supposedly economy and health, which are now often put as in opposition. And I think that in everything related to access to medicines, this is very critical, because today we have a system that uses a fully market logic as the way to get access, and so the market and market forces and market priorities and financial things always prime. So but I think for 20 years some of us have been trying to change that dynamic, but where we failed is actually to change the economic policies, such that instead of economic policies that are geared to improve economic outputs and GDP, etc., we should create economic policies that have as an objective to improve health outcomes. And for your information, there is this new WHO Economic Council that was recently established, or that is in the process of being established, that will be chaired by Mariana Mazzucato, who, as you know, has been writing, she's an economist, has been writing a lot about innovation for the public purpose. And the idea is, how can we rethink economic policies and that they serve public interest, including health, and where, of course, access would then be part of that, instead of seeing health as, at best, an input into the economy. And I think that it's not an easy solution, but I think that's a really important aspect to consider.
Absolutely. Thank you so much, Dr. Els, for your perspective. Unfortunately, I think we don't have too much more time, given that our session is set to close in 3 minutes. But I did want to indicate that this kind of thinking, collaborative thinking on what the future of public health should look like and global health leadership should look like, is an ongoing effort from the IWG. And so for anybody watching, if you are interested in getting involved in this effort, please do reach out to us. I'll hand over to Laura now to wrap things up.
Thank you, Mina. So I would just like to thank everyone for your time and involvement. We hope you enjoyed it and found it as informative, rather, as we did in creating this session. I would like to specifically thank Dr. Els Torello for her involvement. She summarised it perfectly earlier when she stated, "I hope the new generation will be able to shake the tree so that we can build a better global health leadership. We aim to lead as an organisation by our actions rather than our words, and we invite all of you to connect with us and be a part of our future. Diversity is the mix, and inclusion is making the mix work." Thank you very much, everyone, for this.